think we'll make a start. So thank you all for coming along today. It gives me great pleasure to introduce our own lead for breast cancer pathology, Dr. Elena Provenzano, and Sharon Keeling, who is a patient who's had breast cancer and has kindly agreed to share her experiences with us. It's only too difficult to think when you're sometimes sat there with a whole mountain of blocks to cut and slides to stain and everything else that there's a patient at the end of the story. But it's really important that we understand patients are what we're here for, and Sharon's kindly agreed to step in and give her view on the whole perspective. So I'm going to hand over to Elena. Questions in the chat room, please, and otherwise, if you can switch off your videos and microphones, please. And I'm going to hand over to Elena to start.
Thanks, Colin. So most of you will know me. I'm Elena Provenzano. I'm the breast pathologist. I come over to the lab occasionally. I'm usually on the phone harassing poor old Simon and Richard for cases, particularly for the MDT. And I guess I'm going to spend a bit of time today going through the patient pathway and the breast cancer diagnosis pathway to give you a bit of insight into why I'm on the phone making those calls, and why it's so important to get those results right and to get them out to the patient as quickly as possible. For those of you who know me well or who watched the Surgeons at the Edge of Life show, you'll know I have my own breast cancer story, and that my sister died as a result of breast cancer. She was, my nephew was about to have his first birthday. She had just discovered she was pregnant again, and she found a lump in her breast at that stage. So that's how her cancer story started. And I know there's other people on this call who either have personal experience, either themselves or someone in their family who's been on the cancer pathway and who knows how it feels on the other side. So this is not intended to be patronizing, but I think it's really important for us, although we don't see patients directly, just to always keep the patient on the other side of the biopsy in our minds at every step of what we do. So what I'm going to do is I'll start sharing my presentation, hopefully. Hold on a second, get the right view up. Okay, so hopefully that's showing the right version now. And at various stages, I'm just going to ask Sharon to tell us about her story and the patient's perspective on how, it felt being that person, waiting for those biopsy results or waiting to see the doctor to sort of learn the news. So essentially, there are two main ways a woman can get diagnosed with breast cancer. The first is what we call the symptomatic pathway, and that's when a woman notices a change in her breast. It could be that she feels a lump in the shower. Sometimes the breast can look red or inflamed, or the nipple can be indrawn, or there can be a change in the size and shape. And what then happens is that the woman goes to the GP, and the GP will make a referral to the breast unit. And all breast symptoms are regarded as high priority. And as soon as a woman presents to the breast unit with a breast symptom, she gets put on a 2-week wait pathway. So that's why all breast core biopsies are treated as urgent and put on the cancer pathway, because that's the NHS pathway is any woman with a breast symptom needs to be on a 2-week wait. She must be seen within 2 weeks of referral, and those results must be given back quickly. So Sharon, do you want to tell us about your story and how you discovered you had breast cancer?
Yeah, I had just had my third child, and he was about 6 months old. I had a few problems with breastfeeding, and in the shower one morning, I noticed there was a lump quite close to the nipple area. So I'd assumed that it was just something to do with the breastfeeding problems that I'd encountered, and probably left it for a little while, hoping that it would go away. But like most people, when you discover a lump, you keep on sort of feeling that area, and it kept on being a bit of a worry really to me. So I went to the GP. The GP acknowledged that there was a lump there and put me into that referral system that you're talking about. And I think at that time, neither of us were actually that worried, but it was a huge relief actually to know that I was going to be seen as quickly as I was. So it was good to get in the system and feel like something was happening for me. And in my mind, just to get reassurance that there was nothing to worry about. So that's where my head was at that stage.
Okay, so just to touch on, the other main pathway is via the NHS breast screening program. So basically all women are offered screening between the ages of 50 to 70, and this screening is carried out every 3 years with 2-view mammography at each screening round. In the last figures are for the years 2018 to 19. So just over 2 million women attended for screening in England. Of those invited, 70% attended. Of those women, 85,000 were recalled for assessment. So that means they got sent a letter in the post telling them that there was something abnormal on their mammogram, and they had to come in for an appointment to clinic to have that looked at. And around 19,500 women were diagnosed with cancer. So that's roughly 9 women per every 1,000 women screened. Of those, 80% were invasive cancers, but 40%, so just under half, were less than 15 millimeters. So it is picking up these cancers at a very small age. And that's the aim of the screening program, is to detect breast cancer at a stage where it's still treatable for the woman. So when you go, I thought I had my slide with the mammogram machine seems to have gone missing, but I had my own screening assessment 3 or 4 months ago. Hold on a second. There we go. There's a picture of mammogram there. So basically, as part of that assessment, and this happens whether a woman's referred in because she's discovered a lump in the breast, or whether she comes via the breast screening program, the doctor or a nurse practitioner will do a clinical history and do a physical examination, and then they may need to do further mammographic views. I don't know if you can see the picture on the left, but basically with the mammogram, you need to get undressed for the top half. You then put your breast on the mammogram machine, and it gets compressed between 2 plates. So it is not the most comfortable procedure. The mammographers who do it are incredibly experienced and very professional, but it is an uncomfortable procedure to go through. If they then find that indeed there is an abnormality, such as a lump, they'll go ahead and do a biopsy, and that's usually a core biopsy. So it's basically a spring-loaded device that the needle gets injected into the breast and pulls out a slender core of tissue, or else the bigger ones are the mammotomes, and that's usually for calcification, where there's nothing to see or feel, and they need to do a sort of a 2-dimensional process under the guidance of the mammogram to target the right amount of tissue, and that's actually using a much larger needle with a vacuum biopsy. So Sharon, would you like to share with us your experience of what that assessment was like?
Yeah, so I went to the surgical outpatients, sat in the waiting room, saw lots of ladies already in headscarves and obviously undergoing chemotherapy treatment. And to be completely honest, I think like most people that sit in that situation assumed that would never happen to me, and that I was feeling a little bit sorry for them actually, and thought, well, that must be awful. Of course, that's not going to happen to me. Went to see the surgeon and had all of these assessments that you've looked at. So I had a mammogram, which actually for me, I was quite young, so didn't show anything. Had an ultrasound on the lump, and again, there was nothing there. But the surgeon being extra careful and being able to feel that lump, so I was extremely lucky, because it was quite on the surface. So he said, well, we'll just take a biopsy just to be sure, and we'll just have a look, see what that is. I'm not expecting there to be anything to worry about. So I wasn't worried. When I had the biopsy taken, obviously it went straight into formalin. Working in histology myself, I obviously have a sneaky look, make sure it's going straight into formalin, and do that thing that I think most histologists do, where you look in the pot and think, oh, it's sunk to the bottom, so it's going to be all fine. And went off quite happily thinking that I was going to get the all clear. But then a week later, had a phone call asking me to go back in for a rebiopsy because something didn't look quite right. I did that, and I have to say the wait between that biopsy and getting the result was probably one of the worst times of my life, because everything flashes through your mind. Then you're thinking, what is this? What's going to happen? What's going to happen next? And obviously already thoughts are sort of progressing towards not being around for my family anymore. So it was a horrible wait.
Yeah, so it's interesting you say that, because I remember what happened with my sister. So I guess there was partly that thing that you were talking about, because she was, pregnant at the time, and the GP reassured her and said it's most likely going to be nothing. And she had the biopsy and she was expecting the GP to ring with the result. And instead she got the GP nurse on the phone saying, actually, we can't give you the result on the phone. You need to come in person. And of course, that's when I got the wildly panicked phone call. I was at a conference in York, actually. It was 2 a.m. in the morning, and my sister's saying, the GP wants to see me to give me the result. It's, it's cancer. It must be bad news. So it's interesting how just little things like that, like a slight delay, or have such a huge impact on the amount of worry and what the patient thinks that means in terms of their results. So as Sharon said, and as you all know, the biopsy then gets put straight into a pot of formalin, ideally. And if it's sent up to the histology department before 4 p.m, you'll know that evening cut up, it gets blocked and processed overnight, and then the sections are cut and put out with the priority cases the next day. What we do as soon as we get those slides, we screen them initially, because if we need to order any receptors, they need to be done straight away so that they're ready for the next day. So we have those answers for the MDT. So we get the slides usually at 1 o'clock. We review them quickly. We order any immuno or levels that are needed. And that's because the biopsies that are taken on a Tuesday or a Wednesday are discussed at the Monday MDT. And those women have their outpatients appointments on Monday or Tuesday. So if a patient's discussed at the MDT, they have their appointment straight away. That's why it's really important for us to try to get cases ready for the MDT. It's because that's linked to the patient's appointments. And similarly, the Thursday, Friday, Monday biopsies are discussed at the Thursday MDT. So we deliberately allow 2 days. So the biopsy, say, comes on a Monday, the slides come out on a Tuesday, we order the immuno. If it's a cancer, it'll be ER, PR, HER2, or we may order other immuno to confirm the diagnosis. That comes out on Wednesday, and then that patient is discussed at the 8 a.m. MDT on Thursday morning. So it's an incredibly tight turnaround. And the reason we have those turnaround times is because the screening program has really strict quality assurance targets. So the whole idea of screening is for a woman who comes through the screening program, this is a woman that's asymptomatic, otherwise healthy. So the idea is to minimize the amount of stress and anxiety as much as possible. But that's also incredibly important for a woman who has a lump in her breast and who's worried that that lump could be cancer. So with the screening program, the target is more than 95% of women get their results letters within 2 weeks of having their mammograms. If they do need to go back, they need to be offered an appointment to be seen within 3 weeks. And our personal target at in pathology is greater than 90% of patients have to have their biopsy results within 7 days. So the reason for these turnarounds is ultimately to minimize anxiety for the patient, but it also is a quality metric against which our performance is measured by the NHS. So what happens when that result comes through, we discuss it at the MDT meeting. And if any of you are interested in listening into an MDT meeting just to see what happens, let me know, and I can approach the breast unit and arrange for that to happen, because I think that's really useful for you to see how the information we provide is used. So at the MDT for breast cancer, we talk about what's called the three-step process, or the three things we look at. So it's clinical, what does the lump feel like? It's the radiology, what does it look like on the x-ray? Does it look benign or malignant? And what the pathology diagnosis is down the microscope. And those three things have to all match up, which is what we talk about with concordance. So for example, if something looks like a cancer, but I say it's a benign lump like a fibroadenoma, the radiologists and the surgeons have to decide if they accept that diagnosis, or if maybe there might be, the biopsy might have missed the lesion, or and whether that patient may need another biopsy just to confirm it. So, and at the MDT, the other thing is, once we have the diagnosis, is we determine the treatment plan. And it's really important that the surgeons and the breast care nurses have as much information as possible when they speak to the patient for the first time and give them their diagnosis. So I guess, Sharon, do you want to tell us about that first appointment when you saw the surgeon and you got your results?
Yeah, so obviously went back after the second biopsy, which, as you described, what had happened was they'd probably slightly missed the lesion a bit. So there was a little bit on the corner of my biopsy that looked a bit suspicious. So went back in, and obviously at that stage was starting to fear the worst, and was told pretty much straight away that I had a ductal carcinoma in situ. It was a grade 3, and I was told again straight away, which I'm really grateful for this process that you've just talked through, because the minute that I get my diagnosis, it feels like there's a plan. And that's really important, because I think it gives immediately, as I'm told, and obviously I'm fearing the worst, it gives me hope that something can happen. So I was told that I had an ER positive, PR HER2 negative tumour, and that the chances are it would be okay with just a lumpectomy. And however, long story short, I had the lumpectomy, but I had some positive nodes as well. So I went back for a second surgery to have an axillary node clearance. But it was horrible, but also reassuring to know that there was a plan, and to sit with a breast care nurse who could explain it and go through that plan. And I have to say, having known a little bit about histology and breast diagnostics, when you're the patient, it all goes out of the window, and you hold on to those people for dear life for that plan. And you really, really need them to give you all the information and feel like you can put the trust in them to treat you in the best way possible.
So, so I guess sort of from what Sharon's saying, it is, you can sort of deal with what you know. So often it's the unknowns that create the greatest degree of anxiety. And in the last 4 to 5 years, there's been really huge changes in how we treat breast cancer. And in particular, a lot of women now get their chemotherapy before they have their surgery. And that's for certain high risk types of breast cancer, like triple negative breast cancer. And that's why it's really so vital that we have those receptor results as well, because that means when the surgeons and the nurses sit down and speak to the patient, they can give them information, not just to say you've got cancer, but a little bit of an idea of how aggressive that cancer will be and the types of treatment that may be required. Is it just an operation and some hormone therapy? Will there be a need for chemotherapy? And obviously, being told you need chemotherapy is terrifying in itself, because you think of all those women in that first appointment that were sitting in the waiting room with the headscarves and all the horror stories you hear. So I think, you know, that the not knowing is what generates the most anxiety, and that's why it's really important that we have all the information available to give to the clinicians at the MDT, so they can provide as much information as possible to the patient, so that they've got an awareness of, you know, what their diagnosis is and what the future is possibly going to hold in terms of their treatment. So
Can I just add as well to that, just saying that I think one of the biggest issues, and I've learned this since doing some work for breast cancer care and breast cancer now, is that most women feel like they need that element of control over their disease, because obviously they're out of control. This has happened, they can't do anything about it. And I think having all of these answers up front and having a treatment plan gives them a little bit of a feeling of that control, which is really psychologically helpful, I have to say.
Okay, so Sharon mentioned the next step in her pathway was going for the surgical procedure. So those of you who've assisted in cut-up will know either sometimes the surgeon will just try to remove the cancer and leave as much breast tissue as possible behind. So that's a wide local excision, or we call that breast conservation surgery. Although in some cases it's necessary, if it's a really large tumour, to remove the entire breast via a mastectomy. So our standard protocol is to weigh the specimen. We measure it in 3 dimensions. We do this complex inking procedure where we use the different coloured inks so we can work out where the margins are, and that's really important because we need to be able to tell the surgeon if the tumour is close to a margin, where that margin is, because what they might be able to do then is just go back and remove a small part of the breast rather than to do a whole mastectomy. And that's a lot of variables that will determine about that decision. So we'll cut it up, we'll take lots of sections so we can determine the important things that the clinicians then need to manage the patient. So first of all, we need to confirm that there is cancer present. We need to look at the histological type and grade, and that's really important for prognosis and for deciding treatment. The size of the tumour. We've already done the ER, PR, HER2 on the biopsy, so we don't usually repeat those on the excision specimen unless we find something new. And then we need to look at the margin. So can the patient be reassured that her cancer has been completely excised and no further surgery is required? Or is the tumour at the edge of the specimen with the possibility that there's still some cancer left behind, in which case further surgery is needed? If the chemotherapy was up front, sometimes we don't find any cancer at all, and that's really good news for the patient because that means that they have an excellent prognosis. But if there is residual cancer left, we need to comment on whether or not it's responded to the treatment. And finally, we look at the lymph nodes, so the number of nodes we've received, whether or not there's a metastasis, and the size of the metastasis is important as well. So with breast cancer, if it's less than 2 millimeters in size, we call that a micrometastasis, and they don't usually do an axillary clearance. Whereas if it's a larger metastasis, more than 2 millimeters, then there'll be a conversation about whether to do an axillary clearance, which is what Sharon mentioned that she had, or what they'll do now sometimes is they'll give the patient radiotherapy to the axilla. And what happens at the MDT is we use this program called, or the oncologists use this program called Predict, where we put all the information in, so the patient's age, how the cancer was detected, the size of the tumour, the grade, the number of lymph nodes involved, and the ER and the HER2 status. And what that does is that calculates the benefit of hormone therapy and chemotherapy. So in this particular case, of a young woman with an rather large 30 millimeter ER positive HER2 negative cancer. You can see that there was a 3.1% benefit from chemotherapy. So although that seems really small, what will happen at the MDT is if it's 3 to 5%, they will discuss chemotherapy with the patient. And in some cases now, we'll do extra genomic tests like Oncotype or Prosigna that give us a better idea of how the cancer might behave and what the degree of risk is. And if it's more than 5%, that patient will be offered chemotherapy. So I guess you've touched on this already, Sharon, but just how you felt when you had that. And often, as you know, with the surgical excision results, these take a little bit longer. The slides take longer to process. So I think at the moment it's about a 2-week wait for the patient to get those surgical excision results. So I guess, Sharon, if you could tell us how you felt while you were waiting for those surgical excision results and during the conversation you had with the surgeon.
Well, obviously, after the surgery, I was incredibly nervous and was hopeful, like I guess most women, that when I'd had my wide local excision, that I wasn't going to have a mastectomy on the one hand, but then on another was worried that if I didn't, would any of this remain? It's just a real time of anxiety, and chemotherapy was something that everybody dreads. Nobody wants to be told that they're going to have chemotherapy. And I suppose, again, going back to it never happens to me mentality, assumed that that wouldn't happen to me. And sadly, it did. So I had the wide local excision, had 3 of my lymph nodes were positive, and I went on, and I know for a fact my oncologist used this predict scoring as well, which was used later on with some endocrine therapy that I'd had. But went on to have chemotherapy and was sadly one of those ladies in the waiting room with the headscarves on. That was now me.
Okay, so that's, I guess that's the end of the presentation. So what I was hoping to do was to talk through what we do, but also what each of those steps means for the patient. And I guess that's Sharon's experiences, but also my own experiences. I remember when I was going through this with my sister, and any of you who had family members, you're all part of that ride. So at every step, if you're having a scan or that wait for the results is such a hugely anxious time for everyone, and there's really nothing else you think about during that stage. And it's once you've got the information, then you can process it, you can deal with it. I think as Sharon importantly said, you then have that element of control, but until you have those answers, your mind plays terrible tricks on you. You automatically think the worst, and that's what's difficult for the patient. So hopefully this has given you some idea as to, when I pick up the phone and I'm chasing up those biopsy results or the surgical excision results for the MDT, I know what huge pressures the lab's under and all the stress and the incredible work that you all do to get those specimens out in time to get us the immuno results. But at the end of the day, it's about the patient and getting the results to the patient and trying to minimize the stress and anxiety they feel. Because if those appointments get cancelled, it plays all sorts of tricks on people's minds as to the reason of that. They don't think, oh, well, the lab's really busy. They think, oh, it's delayed. It must mean that it's something really bad. So, at the end of the day, we have targets. I'm not worried about targets. I'm worried about the woman and making sure that she gets the answer so that she can move on to the next step of the pathway. I see there's a question from Richard. So Sharon, there's a question about follow-up. So what happened for you in terms of follow-up after your treatment was finished?
So after the treatment was finished, I I had some radiotherapy, had some endocrine therapy, and went to my very last appointment, I think, with the surgeon. And I went to that appointment that day and was really quite positive, was getting all geared up for being told that I'd got the all clear and that everything was going to be great. And this is where my mind was taking me that day. And it's a day that I'll remember forever, because no one prepares you for the fact that nobody gives you the all clear. You are told on that last appointment that you threw everything at it, you gave it your best chance, you'd managed to survive for as long as you had, but there was no guarantees, and that I was sent away and told to be vigilant, make sure I check my breasts regularly, make sure I go to all of my mammogram appointments. But there was no, like you see in the films, you're all fine, you're in remission, you're all clear. There wasn't that. And I have to say, and I don't want to end on a horrible note, but I did go to the car and cry quite a lot, because I wasn't expecting it. I was expecting to be told it was all fine. And I've gone on and I am being extra vigilant, and I am glad for the life I've been given, which others, like Eleanor's sister, maybe, she hasn't had that opportunity, and hopefully I make the most of it and treat each day like it. I know it's a bit of a cliche, but treat each day like it's my last and make the best of it.
Yeah, so I guess formally, Richard, so after a diagnosis of breast cancer, when the treatment is finished, most women have an annual mammogram for 5 years, and then at that 5-year mark, they're sort of discharged from formal follow-up. And what that means varies slightly on the type of breast cancer. So what happened with my sister is, with triple negative breast cancer, at the end of 5 years, if nothing's happened, because that's a very aggressive type of cancer, if it comes back, it tends to come back early. So if you get to the 5-year mark, they sort of say, okay, you're not completely out of the woods, but there's really low likelihood that it's going to come back after that 5-year point. Although there's always the possibility, once you've had one breast cancer, that you could possibly develop another one. I know with my sister, she got to the 3-year mark. Her oncologist was happy that everything was going well, and that's when they found a lump in her armpit. And at that stage, unfortunately, the biopsy showed that her cancer had come back, and she just made it past the 5-year mark. So when she passed away, I think it was 5 years and 2 months after her original diagnosis. But particularly for ER positive breast cancer, we know that that can come back 15 years, 20 years down the track. So I guess it's what, Sharon's comment is, it's always in the back of people's minds that, you never really have the all clear. So.
Elena, can I just ask you, breast cancer is probably one of the most heterogeneous cancers that we've got. And as we get deeper and deeper into genomic information, we're finding more and more different types, which is great and may give more therapy. But just coming back to Sharon's point and your point about the waiting, hanging around waiting for genomic diagnosis or whole genome sequencing at the moment to help treatment, is that an advantage, or is it going to have to be much, much quicker to do anything for patient experience?
I think we're getting better and better. So I think there's 2 things that are happening that are really exciting. So I think the use of neoadjuvant chemotherapy is really exciting, because basically that gives us a signal as to how the cancer's responded to chemotherapy. So we know the worst 2 types of breast cancer are triple negative breast cancer and HER2 positive breast cancer. And for example, with HER2 positive cancer, with the drugs they have now, something like around 70% of women now show a complete response post-chemotherapy. So those women can be reassured that their cancer has responded to the treatment, and they're likely to have a very, very good outcome. So this whole, no, it's not appropriate for all types of breast cancer. And, you know, the turnaround times for those specimens is hard as well, because we need to examine that specimen really carefully in order to be able to say, you know, sometimes it's easier to say that something's there than it is to say something's not there, if that makes any sense. So those neoadjuvant chemotherapy specimens are really complicated. We have to take lots of blocks, but the end result of that is if we can't find any residual cancer, that is really, really good news for that patient. And you know, I can't imagine how they feel when they have their appointments and the doctor tells them, actually your cancer's disappeared completely, you know, we weren't able to find any more tumor. So those specimens are really important. But the genomics now, I guess it's going to be a bit trickier when we start doing the triple negatives through the GLH. But at the moment, we're doing a trial in breast cancer called the Personalised Breast Cancer Program. And what we're doing is, I think at the moment, we're turning around the whole genome sequencing data in that trial in 12 weeks. So it is being turned around quickly enough to make a difference for patients' management. Unfortunately, a lot of the mutations that the drugs aren't available in the early disease setting, so the results are going to be more relevant for the woman, you know, in the unfortunate event that if the cancer comes back, that there'll be specific drugs that will be available at that point. But you know, for example, if we identify a high tumor mutation burden, so if the tumor has lots and lots of mutations, we know those women do better with platinum-based chemotherapy. So we can check to make sure that the woman's getting the right type of chemotherapy and the result comes through quickly enough that we can actually change it if she's, you know, on a different regime to start with. So at the moment it's a little bit slow. That's mainly because the huge amounts of data, and John can comment on this as well, takes a very long time to process, but we are getting faster, and I think those timelines are going to keep coming down and down.
Agreed. I think groups have shown that they can be turned around in a week with all the framework involved. We're just not there yet.
Thank you. Anything else from anyone? Sharon, would you like to say anything at the end, or?
No, I don't think so, other than just to say to everybody that works in the lab that the patient doesn't actually get to see, please don't underestimate how much we rely on the work that you do, and appreciate it in an invisible format. Obviously, I know that you exist, a lot of patients don't, but honestly, keep on doing what you're doing. I know it's hard work and I know you have lots of things to do, but honestly, we rely on you so much, so please don't forget it.
Thank you very much, Sharon, and thank you both for an excellent talk. I think getting a perspective from Sharon as a patient has been invaluable, and hopefully it reminds everybody what we're doing is so important for patient care. So thank you both very much. It's really appreciated. Fantastic talk, and thank you all for attending. And
yeah, thanks again to everyone for all the hard work you do, because we all appreciate it. We know what pressure you're under, and yeah, just keep it up.
Thank you very much. Thank you. Thanks a lot. Bye now.